medical. No, email me with the personal description. Okay. Because I need to let folks know. Okay.
Hello? Hello? Can you hear me? Are you the person? Are you the person? Hello? Hello? Good morning. Good morning. Is this any better? No. This thing just suck, or is it me? Hello? All right. I'm going to be the guy who holds this, even though I really don't like that. All right, well, I finally get to meet you. I was busy last year when we did respiratory. I had to deal with 340 undergrads whose course needed to be entirely online, and that kind of tied me up. But now we meet in person. So this picture I came across recently, and I'm like, oh, what a perfect description of my internship after I got out of vet school. So, got a little icebreaker for you. I didn't get to do it last year. So I got 2 gift cards to Blind Pig, and if you're interested in trying to get one of those, then send to my email by midnight tonight what fruit I was associated with over the course of my clinical toxicology career. All right, so it should be pretty evident. So I have 50 minutes to tell you everything about GI drugs, which, if you can tell from the way I phrase that, I think that's way too short. I asked Dr. Barton, Dr. Credill, and Dr. Hill when I originally made these lectures what drugs they thought were good to know regarding animals. They gave me a list of about 30-plus drugs, and so I pared it down a little bit. But this lecture is mostly going to be me talking, so we got to get through them so you don't look stupid when you get to clinic and it's like, oh, I've never heard of this drug. And then, they come to me and I'm like, well, look, see, we talked about it. So here we go. I do put objectives. My advice is make a table for this because we're going to do some comparing of different drugs in different categories. And definitely if I underline it, know what it means. And if there's anything that's like a clear comparison, definitely definitely know that. But also there's some questions kind of keep you online when you're studying. You guys did not cover vomiting in GI, is that correct, or did you? Pathways of vomiting? Okay, well that's why I've got this. So, basically vomiting, there's two main pathways that cause that. There's what's called the humoral pathway, so substances coming through in your blood, and they reach what's called the chemoreceptor trigger zone in your brain. Have you heard of that, maybe? Okay, that's a part of the brain that doesn't have a blood-brain barrier, so it's exposed to blood-borne substances, and it's kind of a way to sample the blood for noxious substances. All right, and then there's also the neural pathway, nerves coming from your gut or from your brain that go into the, both of these basically ultimately wind up going into the vomiting center. So, we have a pointer. That would be cool. Oh well. So they wind up going into the vomiting center, which is down here. All right. So brain and gut, neural pathways, and then directly in the brain, chemoreceptor trigger zone. And they've got all these different receptors for different types of molecules, many of which you've heard about in your introduction to this course. Okay. So I kind of broke it down with the numbers for you, what's going on. Basically with the gut, and you've got these different receptors that receive signals, okay, different neurotransmitters are involved. It's the vagosympathetic pathway, and so things like inflammation, chemotherapy, which kills cells in the gut, rapidly dividing cells, radiation therapy, all those things can trigger neurons in the abdominal viscera. Also, direct input from the chemoreceptor zone, so things like uremia, hepatic encephalopathy, so you can feel pretty sick from liver or kidney failure. All right, that's where that's registered as different substances build up in your blood with these problems. Different drugs, biotics, also different toxicants, and also endotoxins. That's how endotoxins trigger vomiting. There's also what's called oculovestibular input, okay? And that's your vestibular system. That's over on the side there, number 3. So that's like motion sickness and motion-related illness, problems like that that make you vomit. Dogs and cats differ a little bit. Cats kind of plug more into the vomiting center, dogs more into the chemoreceptor trigger zone. That's not a huge thing you have to keep in mind necessarily, but we will talk about differences in the receptors between dogs and cats, and that actually has some clinical relevance. Cerebral cortex, that's number 4 there. So pain can make you vomit, fear, anxiety before tests. Some people get sick before exams. That's how that plugs in. So that's called psychogenic. Basically, your brain is making you sick. Also, opioid receptors have a role in that. And all these come together in what's called the emesis or vomiting center. That's in the medulla. That has a couple of receptors. Neurokinin 1 receptors, which substance P binds, and alpha-2 adrenergic receptors, which I think you've heard about recently. Those are in there. And ultimately, neurons then go to the GI tract to coordinate the act of vomiting. All right, so you have all these inputs, they come together in the vomiting center, and then they tell your esophagus and stomach to coordinate and your abdominal muscles to vomit. Okay, there are some, I can go back one slide. Mainly this is going to be about dogs and cats. Occasionally you might use an antiemetic in a ruminant. What do you guys think about antiemetics for horses? Yeah, it's not really a horse issue, okay? So, all right, here's some key differences in the chemoreceptor trigger zone. Dogs tend to have more, they're better wired for dopamine receptors, dopamine 2 and histamine receptors. Cats are better wired for norepinephrine, so alpha-2 adrenergic receptors and serotonin receptors. There's like 7 different families of serotonin receptors. This happens to be serotonin 3, okay? Cats, as you see, so we got the dogs with the histamine receptors. Cats, histamine doesn't really tend to cause vomiting as much. So also what's useful about that is antihistamines aren't going to work a whole lot for cats in preventing vomiting. I think I've got that coming up. And the 5-HT3 receptors, that's serotonin 3 receptors, are more prominent in the gut of dog. We've got an agent, a drug that targets that, so that's going to work better in dogs. So this is kind of just leading you into actually discussing the drugs. So there are some differences there. The flip side is causing vomiting. So do you guys know any emetics that are used in dogs or in cats? Apomorphine, okay. And then what's the other one? Xylazine and dexmedetomidine. Which species do you think apomorphine is going to work better in? Dog, yeah, because that is a dopamine agonist, dopamine 2 agonist, so it binds up there in the chemoreceptor trigger zone and triggers. Doesn't tend to work so well in cats, but more of the xylazine drugs. What receptors do those bind? Alpha-2, adrenergic receptors, yeah. So those tend to be a better choice for cats if you're inducing vomiting. Flip side is there are drugs that are dopamine 2 blockers to help control vomiting. Those are going to tend to work better in dogs because they're more wired for that, okay? Also, antihistamines tend to be useful in dogs when you're dealing with motion sickness and things like that. See over there the vestibular input? Cats, not too many of the histamine receptors. So it helps for dogs with vestibular type illness that causes vomiting. Okay, so I think I just kind of, on this next slide, I think I just kind of covered what I was going to do here, what may be better antiemetics for dogs and cats. So these are some of the ones we're going to go through. This is where they work. See, a lot of them work through the chemoreceptor trigger zone. The ones like ondansetron, which are serotonin 3 serotonergic blockers, all right, those work actually in the gut, bind the neurons there that are triggering vomiting. So we're going to go through each of these. Notice there's some overlap in the names. You see a couple of common names that show up in at least 4 different categories. What do you guys see? Yeah, so prochlorperazine and chlorpromazine, all right, those are phenothiazine drugs that block dopamine 2 receptors. Notice how they show up in multiple categories. That's because they actually block a lot of different receptors, so we'll touch on that. Okay, so they can have kind of multiple ways they have an effect on the whole vomiting system. All right, so let's talk about histamines first. And there's histamine 1 receptors, and then there's histamine 2 receptors, which we're just going to focus on histamine 1 receptors right now. Now remember, those are important for also like controlling mast cell degranulation. So have you talked about mast cells yet? Okay. So antihistamines prevent them from degranulating, which actually might have some local effects in the gut if you're having a mast cell related cause of vomiting. But they also are good because they block signaling of histamine receptors in the chemoreceptor trigger zone and also in the vestibular system. So these tend to be really good for motion sickness in people and in dogs. And you might recognize some of the top 3 there. Diphenhydramine, which is Benadryl, dimenhydrinate, and meclizine. I underline the names that I want you to know, which are the generic names for the drugs. So those are the three that tend to be used. There are other, what are called first-generation antihistamines, like hydroxyzine, chlorpheniramine, things like that. And you'll see these if you go to the drugstore and get them, but they don't tend to be as effective. The thing is, with pharmacology, different drugs that are in a category, they each have their own character. And so some are a little more subtly good at one thing and maybe not so good at something else. So these are the ones that tend to be the best. These three are the ones that tend to be best at blocking H1 receptors and bringing vestibular-related vomiting under control. Okay, there's also second-generation antihistamines. Those really don't do a good job, okay, as far as vomiting is concerned. They do a good job otherwise with mast cells and things like that, but they're not too good for vomiting. All right. Does anyone know the difference between first and second generation antihistamines?
Isn't it where first generation for the first ones like actually produced after the patent ran out with the second generation?
No, that's just an issue of generic versus brand name. What they are, though, is, actually it's a long story and I don't want to get into it, but there's an interesting angle to that as far as, yeah, but what they are actually, do you remember like Benadryl? What's the main side effect you think about? Sleepiness, all right? These guys on the bottom don't cause sleepiness, so why would that be? That's a nice answer, but not quite. Hand in the back. Yeah, these second generation guys don't get into the brain. The first ones do. So the first ones all cause some degree of drowsiness. The second ones stay in your periphery and are busy dealing with mast cells and stuff like that. Okay, so yeah, I guess they might be a little effective at the chemoreceptor trigger zone, but not enough to be a benefit, and they certainly aren't going to get in the vestibular area and deal with that. So, big side effect is sedation, and that's because first generation goes across the blood-brain barrier, second generation does not. You guys talk about P-glycoprotein transporter by any chance? My favorite transporter? Okay, so then you know that P-glycoprotein keeps things out of the brain as well as a lot of other directions it moves things in the body, okay? And so P-glycoprotein keeps the second generations out, but the first generations get in. So that's why you have that. Now, first generation antihistamines also have all these other effects. They block muscarinic acetylcholine receptors. They block alpha-adrenergic receptors. They block dopamine 2 receptors. Some of them, mainly cyproheptadine, block serotonin receptors. And I'm kind of including this because I don't think anyone else is going to talk to you about any histamines because I don't see a derm pharmacology lecture, okay? So, plus the second generation ones, they don't bind those other receptors. They just focus on blocking H1 receptors, okay? So that's kind of histamine antagonists in a nutshell. Now there's another class of drugs. Are you familiar with like acepromazine and chlorpromazine? Those are the two used most commonly in veterinary medicine. These are the phenothiazine class, okay? They focus more on dopamine 2 receptor blocking, okay? Now, if you look at the structure, I included this, if you blur your eyes a little bit and look where the carbons are, you can see Benadryl, diphenhydramine, they're very structurally similar. And because of that, they also block the same sets of receptors. Muscarinic receptors, alpha-adrenergic receptors, histamine receptors, histamine 1, dopamine 2, okay? And then there's the, some of them, mainly chlorpromazine, block serotonin receptors. That'll be important in toxicology if you're treating serotonin syndrome, but not so important today. The three up top, these are the ones that tend to be most effective for treating nausea. Okay, acepromazine just doesn't do a good job with nausea, but it does other things, all right? So those three phenothiazines do a decent job. Tend to be better for dogs because dopamine 2 receptors, dogs are better wired for that. You can try it for motion sickness in cats because they do have some alpha blocking effects, more so than the antihistamines do. All right. But it might not be the best, but you can try it in a kind of a tight situation. All right. So also acepromazine likes to kind of sedate your patients. So you get patients that look like that, and that freaks owners out when the third eyelids elevate. So. All right, so main side effects, and I'm all about side effects, because my interest is drugs can do good, but drugs can also harm. And as a toxicologist, I'm like, oh, drugs do harm, that's cool. So I'm more about that. So make sure that you kind of have a feel for, when you go into practice, the problems drugs can cause, and that you're talking with your clients. Don't scare them, but kind of, here's things you need to watch for. All right? So here's some drawbacks of phenothiazines. Sedation, and it may be more marked than with the antihistamines, okay? Low blood pressure, that's because of it, they block alpha-1 receptors to some extent too, okay? Definitely more than the antihistamines. They also have antimuscarinic effects, not as much as the antihistamines. What are some antimuscarinic effects that you learned recently? What's that? Slow down the GI tract, that's an important one. Yeah. Yeah, so dry mouth, elevated heart rate, things like that. Yeah, what species of animals do you have to be really careful with slowing down the GI tract? Ruminants, horses, yeah. So be careful. All right, here's another one, metoclopramide, or Reglan, okay? This too is used as an antiemetic. Low doses, it blocks dopamine 2 receptors. It also is used because it is a serotonin 4 agonist, not a blocker, but an agonist. Serotonin 4 receptors, basically, when those are bound, they kind of stimulate upper GI motility, and you're like, oh, that's bad because the gut's moving and they're nauseous. Actually, it's good because it moves things along the gut and gets them out of the stomach and moving on down, all right? So, the dopamine 2 blocker, 5-HT4, that's serotonin agonist. And then it's a serotonin 3 blocker, which we'll talk about in a sec. But that's only at high doses, and it's better if you not go to the high doses. So kind of focus especially on 1 and 2 as being your main things. Again, doesn't do a great job in cats due to lack of dopamine receptors and the chemoreceptor trigger zone. Doesn't tend to have too many adverse effects at normal doses. Sometimes it'll just mess a little bit with the rest, with the mental state. Not too bad. Don't combine with phenothiazines. Why do you not want to combine with phenothiazines? What's the main thing phenothiazines do? You can go back 2 slides. What's that? Yeah, dopamine 2 antagonist. So you'd be doubling up on the dopamine 2 blocking, and that's actually how you get like more effects like that. All right, it's by messing with blocking too much dopamine. Okay. And it wouldn't be a good pharmacology lecture without pictures of bottles, right? That's what I noticed in vet school. Now I get to put the bottles on the slide. All right, You guys heard of Zofran and Enzamet? Okay. These, the way they work is they block serotonin 3 receptors. And if you look back at those diagrams, you know, those are in the gut and the chemoreceptor trigger zone. So, you know, parvovirus enteritis, things like that. And other problems that trigger the chemoreceptor trigger zone, these block those signals, okay? So ondansetron and dolasetron are the two used primarily in veterinary medicine. So they're really good for gut-related problems, such as this really revolutionized, in a sense, treating people and animals with cancer, because it really helped bring chemotherapy-related nausea and made it a little more controllable for people and animals, but it's hard to gauge in animals. So they're really good, useful if you're going to be an oncologist. Very good for inflammation, which especially dogs like to get from all the things they eat, and good for infectious causes of GI disease. The other one is meripatam. That one is NK1 receptor antagonist, and so substance P binds NK1 receptors. That blocks that. And so if you look back, those are in the gut, those are in the chemoreceptor trigger zone, and those are also in the vomiting center. So we're blocking that. This also tends to be really good for GI insults, okay? Things going on in the gut. All right, this is FDA approved for preventing acute vomiting and for prevention of vomiting due to motion sickness in dogs. That's the oral form. And then dogs and cats with the injectable form. Okay, Serenia is the brand name of that. Interesting side note, if you read the package insert on Serenia, they proved that it was efficacious for motion sickness. Basically, 122 beagles went on car rides with or without Serenia on board, and they rated them on how nauseous they got with or without Serenia on board. And that's in the package insert, and that's how they got the, at least the approval for treating motion sickness. So. All right, cannabinoids. I'm not going to talk much about them, all right? I've included some things if you want to educate yourself a little bit in the content in I guess it is ELC, right? Yeah, okay. I sometimes get confused because undergrads use some different things for part of their courses, but ELC. Just know that there are different cannabinoid receptors, CB1 and CB2. This is not tetrahydrocannabidiol, okay, so it doesn't have mind-altering effects. Last time I checked, a couple of years ago, there were no studies on efficacy. The DEA, the problem is the DEA has not approved it, basically cannabinoids for anything, and so it's kind of a licensure, controlled substance, keeping your license type of issue. So I'll leave you to navigate that. I did include some stuff from the Georgia, the Georgia Veterinary Medical Association on why you probably may not want to use these things for now, and given the part of the country we live in, these things are perceived as bad, even though they have no psychotropic effects. So you might want to think about it before prescribing them, okay? And someday that might change, okay? There is an FDA approved for people, cannabidiol, that's Schedule 5, and you'll learn with your pharmacy person who comes in to talk what that means. But Schedule 1 is like has no use and is horrible and can never be used, versus Schedule 5 is not so bad. So, all right, mean break. What do these three have in common? Besides being about vomiting. That's true. They're eating their regurgitation. The cat's not necessarily. There's a more unifying theme, and it's subtle. No? Anyone?
Are they your pets?
No, they're not my pets. All my cats are black, and they do vomit. So, all right, all three play off of other memes. Okay, and these maybe are historical memes. You guys are a little, this is a fairly recent one, actually. So this one is called Roll Safe. This is the most interesting man in the world, and this is Scumbag Steve, and they're all playing off of those memes, and they're about vomit, so they're very clever. All right. We're not going to go crazy with this, but this is a motility review. The main things I want you to know is there's stretch receptors in the gut. Hopefully you remember that. And so this senses when you got like a bolus of food in there, and so things constrict on the mouth side and they loosen up on the rectal side, okay? So you're propelling food through the gut. All right. And on the mouth side, acetylcholine and substance P, which are the NK1 receptors, those cause contraction. Okay, we're less interested in relaxation. All right. Also, muscarinic acetylcholine receptors, because of this, because of their role there, they also have roles in secreting liquid into the lumen of the gut, mucus, stuff like that. So muscarinic acetylcholine receptors are used often to increase motility of the gut and secretion, okay? If you want to stimulate these things, let me see one sec. Yeah. And then NK1 receptors with substance P, those also stimulate motility. So acetylcholine and substance P stimulate motility and secretions. So kind of keep that in mind. Serotonin and dopamine. Did you know that most of the serotonin in your body is produced in your gut? Okay, and then it basically is released into the interstitial space. It binds neurons. That's what this is showing in the middle here. Okay. Sensory fiber with serotonin receptors, and then basically gets sucked back into the cell. So these are micrographs, and all the green dots are serotonin, cells of serotonin in the gut. All the red ones show serotonin transporter, which pulls serotonin out of that interstitial space after it's been released. Okay. So those sensory neurons in the gut have serotonin 3 receptors, and they stimulate acetylcholine release, and you get motility on the proximal side, okay? The serotonin 4 receptors also stimulate acetylcholine release. It's a more subtle effect, okay? Dopamine receptors, dopamine 2 receptors, they block acetylcholine. So maybe you can predict where we're going to go with this. We're going to be talking about serotonin, dopamine, and acetylcholine. 4 big types of diarrhea, okay? Osmotic, inflammatory, strictly a motility problem, and secretory. Osmotic is like you're pulling things into the gut, because you've got something in the gut lumen that's drawing water in. And secretory is you're secreting into the gut for other reasons. All right? And if you're trying to treat diarrhea, you got to think about what type of diarrhea, what's the cause, and that'll help you select your choice. All right? And you can sometimes, if you want to just kind of modify motility non-specifically, that's okay. But it's better to kind of think about what's going on and choose a drug based on that. Some things to keep in mind. You don't want to keep, so if there's an enteritis due to bacteria, it may not be the best thing to totally slow the gut down and keep all those toxins from the bacteria sitting in the gut. So kind of take that with caution. Also, a big no-no is if the gut is blocked, you don't want to stimulate motility or slow it down. You want to leave it alone and figure out how you're going to deal with the obstruction, okay? So especially with horses and cattle, they tend to have a lot of infectious causes of diarrhea, so you want to be careful slowing them down, especially, remember, if you slow down a rumen too much, you're going to get rumen stasis and you're going to get a dead cow. So kind of be careful with these things. Now, I don't think it was mentioned in the prior slides, there are also opioid receptors in the gut, okay? So endogenous opioids. Opioids have the interesting effect of causing constipation. So if you need to slow the gut down, you might consider a mu agonist that stimulates the mu receptors, okay? But you got to be careful, because remember, opioids can get into the brain, CNS depression, respiratory depression if you use a big enough dose. You don't want that. Mainly this is used in dogs. And there's a couple of them. There's loperamide, which is Imodium, which you can get over the counter. And there's Lomotil, which has two things, diphenoxylate and then atropine. Diphenoxylate is more of a controlled substance, so that would have to be prescribed. Okay? Those are a couple of opioids that you'll hear about that you can use just to kind of slow the gut down some if you feel that you want to kind of non-specifically do that. Something else practitioners tend to use, anticholinergics. Okay, so let's block cholinergic signaling. So atropine, and then that Lomotil, which was on the last page with the opioid, that also has some atropine in it. Okay, there's some other ones used, not so much in veterinary medicine now. Those all block muscarinic receptors. Okay, so they slow down motility, they slow down secretions, they tend to take the edge off of feeling sick. But again, especially in large animals, you got to be careful that you're not going to slow down the gut too much and get like rumen stasis or slow down the horse's digestive system. They can also, if you're not careful, you get tachycardia, urine retention, things like that. The use of atropine to slow the gut down is kind of less commonly used than it was because we're kind of coming up with better options. But I'd like you to be aware of it, and it is an option to consider. Just you got to be really careful. Okay. Now we're going to flip. So the takeaway, if you're paying attention, is there's some things we can do for diarrhea, but they tend to be non-specific, and a lot of times you're better off not trying to mess with the gut motility when you're dealing with diarrhea, but there are a couple options for you. What if you need to move things along, okay? Well, that's where we talk about prokinetics. So like ruminants tend to get like ileus and things like that. So here's a whole list of ruminant problems. Hindgut fermenters tend to get their own problems with the colon, with gastric ulcers. Bunnies like to get the stomach slows down. Dogs, things sometimes slow down with inflammatory disease, definitely post-operatively, like you did in enterotomy or intestinal resection. Megacolon, which we'll see a picture of that in cats. One key thing, if you're thinking of speeding up the gut, definitely don't give a prokinetic if they're obstructed. Because then you're going to be like, the gut's trying to move and there's something there blocking passage through the gut, and you're just going to make it worse. And they're going to hurt worse. So ileus is just when the gut in general kind of stops moving and you get a lot of gas and water in the gut. This isn't a rabbit. So it just shows the gas-filled intestines. Some prokinetics you might encounter, erythromycin. If you ever take an erythromycin, it makes you feel a little bit nauseous. Some people a lot nauseous. All right. What it does is it's an agonist at motilin receptors, and that's a little molecule that kind of has an endogenous role in speeding up gut motility. Okay. and it basically helps contractions in the stomach and the small intestine. Erythromycin at low doses, and this can often be like 10% of an antimicrobial dose, has that prokinetic effect. Tends to be used in horses and cattle, okay? And I guess the little ruminants too. Dr. Cordell says there's good evidence for its use in abomasal, but also cecal disorders in ruminants. So I haven't seen it used as much in small animal species, but it tends to be used more on the large animal side. Metoclopramide has some prokinetic properties too. It stimulates those serotonin 4 receptors. At the same time, it blocks the dopamine 2 receptors. Remember the dopamine 2 receptors? If I recall, they stimulated acetylcholine. Well, by blocking those, you're kind of easing up on the front end of motility and kind of encouraging the other side of the bolus of food to move through. So it kind of has its effects through those. It's good at kind of helping empty the stomach, helping move things along the intestine. Doesn't do much for the back end. Doesn't really tend to target the colon. So if you had like constipation, it's not going to do a whole lot for constipation. Tends to be used mostly in dogs and cats, occasionally in ruminants, though it's not that great per Dr. Cordell. Another one tends to mainly be used in cats is cisapride. So if you get megacolon and then they get this inspissated feces just kind of sitting there in the colon, and the colon gets stretched and dilated and loses its motility. It's related to metoclopramide, and it also stimulates serotonin 4 receptors. Generally needs to be compounded, okay? And so this is used in cats with megacolon or chronic constipation. It's been tried in horses. I don't know how effective it is. My feeling, based on what Dr. Barton said, is it's not that effective. And it doesn't tend to have many adverse effects other than kind of cramping and diarrhea, so some things like that. You got to watch for drug interactions. This used to be on the human market, and you had drug interactions, and so people would get arrhythmias and die because they took it with drugs that it didn't interact well with. So I encourage you, if you're going to use that, to take out your formulary and have a look, see what other drugs you're giving or thinking of giving, and making sure you're not going to run into any interactions. And you can use cholinergics, so this time we're stimulating muscarinic receptors. So bethanechol is sometimes used, and neostigmine is sometimes used. These are different ways they work. So bethanechol, okay, so parasympathomimetic, or mimicking the parasympathetic nervous system. Bethanechol kind of triggers muscarinic receptors. Neostigmine blocks acetylcholinesterase. So if you block acetylcholinesterase, what's going to happen to levels of acetylcholine in the synapse? Yeah, I saw someone point up, so that's good. Yeah, you're going to increase acetylcholine in the synapse, hence more signaling to the muscarinic receptors and nicotinic too. It is used sometimes in large animal species, so that's another one I'm mentioning. So you've encountered, you got to be careful. It tends to be good for Dr. Cordell for ileal problems and cecal disorders in the ruminants. Occasionally, Dr. Barton said, uses adjunctive treatment, so it's not going to be the main treatment, but kind of a side treatment for equine stomach ulcers. But what do cholinergics do? Someone mentioned SLUD signs, okay? And so you got to be careful with your dose, or you're going to wind up with muscarinic signs. Okay, bradycardia, vomiting and diarrhea, so you're kind of overdoing it with the GI motility, drooling, tearing, things like that. So you got to be careful. Here's one that is used at Georgia, and Dr. Barton says they tend to use it a fair amount. It's used around perioperatively, so around the time of surgery or postoperatively, to try to prevent ileus in horses, okay? Lidocaine is a local anesthetic. Did you guys touch on those with Dr. Wagner? Okay. Local anesthetics block sodium channels, so they prevent like neurotransmission. So you put them locally and you're preventing neurotransmission, axons coming from brain receptors. This is given IV. All right, and to be honest, I was sitting there thinking about this, and I'm not sure how it does all these effects, because it kind of dampens neurotransmission. So I can see it kind of suppressing like sympathetic tone and suppressing, pain mediated through the brain. All right, but I'm not sure how it increases duodenal contractility. So I'm not quite sure on the mechanism, but it's a local anesthetic, and it is used sometimes. They found it to be useful in horses who've had intestinal surgery. You got to be really careful. It's a great drug. Any of the local anesthetics are a great drug to overdo it with your patients. So the levels that are therapeutic versus the levels that are toxic, going to cause harm, are kind of close. And you tend to get problems like arrhythmias, low blood pressure, things like that. Horses are a little more resistant to that. That's the good news. So this is one to be very careful with. I think you will encounter local anesthetics more when you talk about anesthetic agents and surgeries and pain and stuff like that. Laxatives, you're definitely going to use laxatives. They're not on the exam. Never give a phosphate enema or a saline enema to a cat. That's a good way to kill a cat. That's my comments on the whole thing. So avoid phosphate and saline enemas in cats. All right, motility break. This is called when the diarrhea strikes. I liked that one. It made me laugh. All right, let's race to the end here. Gastric secretion. Normally, histamine 2 receptors, not one, but now we're histamine 2 receptors, acetylcholine muscarinic receptors, and gastrin receptors, all three contribute to stomach acid. Okay, and so the lumen of your stomach and upper duodenum, we've got all these nasty things. Acids, we've got digestive enzymes, whole lot of stuff that likes to harm cells sitting in there. Now, we've got protective mechanisms, especially local prostaglandin production, contribute to there being a layer of mucus, of bicarbonate being secreted to neutralize the acid. So prostaglandins can be protective. The problem is if you disrupt the integrity, if you damaging cells in the mucosa, either mechanically or a noxious substance is killing them off or something like that. If you're messing with the protective mechanisms, then you're going to make a situation where you can start getting ulcers. And these tend to be seen in the stomach, duodenum, and also lower esophagus if you have gastroesophageal reflux. Very common, notice I've got all these starred, very common in performance horses and foals. There's certain conditions which dairy animals like to get abomasal ulcers. A lot of illnesses in dogs and cats can cause stomach ulcers, including renal failure, liver failure, things like that. Side effects of non-steroidal anti-inflammatory treatment. You haven't had your NSAID lecture yet, if I recall, but NSAIDs basically block prostaglandin production, so it would make sense that if you block those, you're taking away protective mechanisms. And also corticosteroids, so cortisol and related drugs, those like to cause ulcers. What can you do? There's antacids, basically, and they just kind of physically neutralize, all right? They don't tend to work too well, all right? So you might consider them in a mild case, or you might consider them someone calling you at night in the, and they're like, oh, you're talking to them like, oh, maybe this dog needs an antacid. they don't tend to dissolve well in the gut in small animals. So they can fool you. This is my practice tip. They can fool you to thinking you got a coin in there, and then you go in and do the gastrotomy, and you've got an antacid tablet, and you feel like a dumbass. So I've experienced that. So they don't tend to work too well, and don't get fooled. All right, H2 specifically, H2 blockers, so famotidine, cimetidine, all these actually you can get over the counter. They decrease acid production because they're blocking the H2 receptors that stimulate acid production. Dr. Hill feels they don't work in small animals. I would counter that. I think she sees like bad cases, and they might help some for mild cases. So there's something you can try, but if they're not helping, you got to step it up. Famotidine, you give, gosh, now I can't remember, it's once or twice a day. I would stay away from cimetidine. It's a 3 times a day drug if you want it to work good. And it inhibits some of the P450s, so drug interactions. So try to lean towards famotidine or ranitidine if you're going to use it. Proton pump inhibitors. These are the pumps. This is the gastric lumen where that pump is. They put H+ ions into the stomach lining, and chloride also comes across to form HCl. So omeprazole, esomeprazole, things like that. Yeah.
I have a question, sorry. Back to ranitidine.
Yeah.
I know I'm not keeping up all the details, but it was taken off the shelves
Was it?
a while back.
Okay.
Or
Is it bad?
I think it was like carcinogenic ingredients or something.
Oh, I thought I saw something about
I was just wondering if we see that in animals at all, or
that.
I guess not, since you.
I don't tend to worry as much,
Yeah.
and I'm not sure that we could do a lecture on do things we worry about cause cancer actually cause cancer. So, but I tend to, famotidine is the one I reach for, if I were still seeing animals as a practitioner, which I'm not. All right. These block H+ secretion. They tend to work pretty well. It takes them a handful of days to work, okay? And you see them tend to work well in dogs and cats. There are equine pastes for gastric ulcers and horses. GastroGuard is omeprazole. You'll notice some different dosages in how much you give prescription versus what they can get at the feed store. We're almost there. Sucralfate. That kind of just binds ulcers and coats them. Doesn't work great, but it helps along with other things. And then if you have, this is specific, prostaglandin toxicosis, ulcers due to NSAIDs, you can actually give an analog, so it's basically the same, you're related chemically to prostaglandins. Okay, it's called misoprostol, and it can kind of help you're like replenishing the protective prostaglandins by doing that. So that's a specific use, but NSAID ulcers, cause ulcers are a common thing. Be careful, it actually is, it's not a good one, but it can be used to cause abortions. So you gotta be careful with your clients that are using it. There, we made it. The GI tract in 51 minutes.
About the proton pump inhibitors,
Yeah,
are you using those as antacids?
I don't use, well, personally I use them. They're not antacids. So when I hear the word antacid, it's a word used generically. To me, you have to be specific. And antacids to me are the things like magnesium hydroxide and stuff. But it does decrease the acid secretion. It's pretty good. It really shuts those pumps down.
So the
proton pump inhibitors is stopping the H plus from going out. So,
Yeah, this little pump that puts, I think it takes sodium in, puts hydrogen ion out into the lumen of the stomach, and it stops that pump so you're not putting hydrogen ion, which forms hydrochloric acid into the lumen. So that's how they work.
So it does nothing for the actual like chloride or like the H. You know, I you see what I'm saying?
Yeah, well, the problem is H plus is the bad part. Not the
Okay.
chloride.
Okay, cool. Sorry, thank you.
Is this one just bad for cats because at low doses it's an agonist, and then at high doses that's when you would treat for a cat, but you don't want to use the high doses?
Yeah, and those are different serotonin receptors too. Those.
Oh, okay, I got you.
It just doesn't tend to work well because cats don't tend to have the dopaminergic
Okay.
D2 wiring.
Okay. Okay, sounds good. Thank
Yeah.
you.